actually reflects the multiplicity of joints. It's obvious if you have lots and lots of joints affected, you're going to have a symmetrical pattern of arthritis. And rheumatoid arthritis is characterized by lots and lots of joints being affected. Tenderness of the metatarsophalangeal joints, and of course the presence of rheumatoid factor or anti-CCP, and X-rays that may show ways of damage. So these have been suggested as ways of trying to determine which of those patients you see with aches and pains have very early rheumatoid arthritis. And this is a useful practical approach. Some other clues. Most rheumatoid arthritis symptoms, oddly, begin in the winter. In most people, it's a slow onset. But as I said, there's variability in the way this disease presents, and it can be, in the minority, quite abrupt and difficult to distinguish from polymyalgia. You don't see polymyalgia rheumatica much in this part of the world, but in Europe and North America, in older people especially, it can be a difficult condition to distinguish from rheumatoid arthritis. Or it may be palindromic in presentation, with pain coming and going, sometimes lasting for days, sometimes for weeks, and then disappearing completely. Intermittent. Again, is that the same disease, or is it something else? If there's a positive rheumatoid factor, it probably is the same disease. The symmetry then reflects lots and lots of joints being involved, and as I say, that is the hallmark of rheumatoid arthritis. Women are somewhat more likely to be affected than men, and that is true mainly in middle life and early years. But with older populations, more and more men affected, characteristically men are affected later in life, and if you look at incidence as opposed to prevalence, over the age of 60, they're the same. And that is why the ratio taking all ages together is about 3 to 4. It's useful to remember the ARA criteria too in defining early rheumatoid arthritis, because it picks up some of the points I've already made as being characteristic of rheumatoid arthritis. These Arthritis and Rheumatism Association criteria were used for decades for defining rheumatoid arthritis in studies, but in a clinical sense they are useful too in identifying those who have evolving rheumatoid arthritis. So it's again the stiffness, arthritis affecting 3 or more joints, the hands, the symmetry, nodules, rheumatoid factor. So picking up on some of the things that the earlier authors I quoted had defined as being useful ways of identifying this disease. I'm just repeating some of what's already been said, but I draw your attention to point number 3. The addition of new imaging techniques can be very useful in trying to determine which patient who has pain in the hands actually has swelling. Ultrasonography is taking off in a big way in the UK. And many rheumatologists are getting to grips with the technique because it can identify swelling that you can't see with the naked eye. So if someone has pain and stiffness and satisfies some of those earlier criteria that I mentioned, perhaps a modest elevation of CRP, even if they're rheumatoid factor negative, and they have ultrasonography evidence of swelling of the small joints of the hands, they have rheumatoid arthritis, most likely, assuming there's no other obvious explanation. So the addition of ultrasonography is making a big impact on this definition of early rheumatoid arthritis. So as I say, it's becoming a bedside tool. MRI is equally sensitive, but it's expensive and it involves expertise which is not available at the bedside, but it is an alternative. I draw attention to the shared epitope. That is a rather convoluted way of looking at susceptibility. It doesn't greatly enhance the likelihood that someone with aches and pains has got rheumatoid arthritis. And there's some laboratory evidence to suggest that if you take synovial fluid and look at the cytokines in the synovial fluid, you may find a pattern that more resembles rheumatoid arthritis than, let us say, psoriatic arthritis. But those are laboratory techniques. This is an MRI of a patient with rheumatoid arthritis. The polar areas are those which are inflamed. There's synovial swelling here. This is a patient who actually has clinical evidence of rheumatoid arthritis, and the diagnosis is not in doubt, but I show it to make the point. What you are usually led to consider then in the patient presenting with pain in the hands, with stiffness, perhaps with a history of swelling, but not necessarily any visible evidence of swelling, are these conditions here. Psoriatic arthritis is the one that you mainly have to exclude, but it may not matter much because the management is the same. Osteoarthritis, and sometimes osteoarthritis and an inflammatory condition like rheumatoid arthritis coexist, and then the distinction becomes more problematic. Connective tissue diseases like lupus and scleroderma rather less. There are often clues such as Raynaud's phenomenon, which is not a feature of rheumatoid arthritis, reactive arthritis or Reiter's syndrome, which tends to affect larger joints predominantly, has an abrupt onset. Again, there are usually other clues, and you notice this becomes fainter. Viral arthritis, well, that diagnosis is made far too often. There are very few viruses which can actually cause an arthritis, and I'm not going to enumerate them here. But that's a sort of differential diagnosis. Here's a patient who's got both rheumatoid arthritis, you see swelling of the metacarpophalangeal joints, but she's also got osteoarthritis, which is of long standing. And it's in this sort of patient that the distinction can be difficult. Remember, I'm still talking about that early recognition of rheumatoid arthritis. Why important? Because I go back again to that first slide, because it is reckoned today that early recognition and early treatment is what's best for the long-term outcome of the patient. The British Society of Rheumatology then has devised this algorithm for both the referral and management of patients with early rheumatoid arthritis. So a patient with joint pain goes to see the GP, who is urged to refer the patient on to either